invite you to this session, just as some of you have already done, so that you present yourself, introduce yourself in the chat, tell us your name, your specialty, and the organization that you belong to. And as always, it's wonderful to have you here with us this afternoon. We remind you that we have translation interpretation services, and you can access them through, you go to where it says more, you click there, you click on interpretation, and then you can choose where you prefer to be, in English or in Spanish. Reviewing the agenda with you, I would like to give you the general guidelines. The project of TTLP is continuing educational credits that you need to get them. We have the pre-test, the practice with our cardiologist. There's a post-test, questions, discussions of a clinical case, and we will have the announcements and the closing, where we will let you know about the topic of next week. So as a friendly reminder, you must register in order to get your credits for continuing education, and we can do that through the link that Julio Acevedo sends you, through that link. So once you see that link, please, those who have not yet registered, please register. And we invite you to turn on your cameras whenever you can, so that you can participate through the microphone or the chat, because we want this to be a collaborative learning experience. I'll talk to you a little bit about our objective today for this program, which is to connect specialists from academic centers with providers in rural sections and areas in order to provide better practices and allow patients to have better access to quality services. So we have a digital library where you can find all of these sessions recorded with, and you will have the catalog of the providers of, and in this technology echo, we exchange knowledge between academic and specialist doctors with providers of primary care, and that translates into the treatment that patients receive. These credits are valid for doctors, medics, and nurses, as well as nutritionists and primary care doctors. So it's important that you register in this session and to complete the pre and post test. Now we go forward, or not. I am going to, I'm sorry, please forgive us a second. Okay, do you see the screen? Good, thank you. Following with the topic of the pretest, you can see it on your screen, and you can also enter into the link, or it should be on your screen. So let's leave that open while we go with today's session, and we have the participation of the cardiologist María A. Rodríguez Santiago. So welcome, and the microphone is yours. Hello, good afternoon, everybody. It's a pleasure to say hello to you. For those of you who don't know me, I'm María Alejandra Rodríguez Santiago. I'm cardiologist and board certified, and I'm in Guaynabo at your service for whatever you need. We're going to begin with the presentation of secondary prevention after an infarct to the myocardium. These are the objectives. So let's move forward to take advantage of the time. Again, we always start with why this type of knowledge, and why is it super important to analyze and know how to deal with secondary prevention matters. That's because the risk of a repeating event, of a secondary event, of having another heart attack is very high within that first year. That first year is the one with the highest risk for the patients for them to have a repeat event. In those first 30 days, which is the time right after the discharge, that patient is 6 times at a higher risk of having a heart attack, and about 50% of the patients have another heart attack within the 3 months of having been released after the first event, and 1 out of 5 patients survive a myocardium attack, and those people will probably have a second event within that first year, and that gives us 18.3% of the patients that experience a cardiovascular event. So in that first year, they usually have another one. Visually, I wanted to put it like this so that you could see that that first month is essential to give our patients follow-ups so that and to be very emphatic in what we're going to be talking about in modifications in their lifestyles and the compliance with medication, especially because it's the most critical time. After that, then we have the 3 months or 90 days where we can have 50% probability of a re-event, and throughout the rest of the year, they can still have a second event. So talking about that briefly, it's important to know why this happens because patients are very surprised because throughout that period right after, since they are scared, they tend to be very compliant with the therapy. It's when they're most compliant with the therapy. And their mind has shifted to, I want to do change, I want to exercise, and these events can happen again. And they it's important that we know why they can happen because physiologically, that artery inside it's still inflamed, it's still swollen, so it's the critical time, the most critical time. So we're going to learn the strategies, which I divide them in 4, and that's how I try to remember or remind myself that I don't miss anyone. So we have the antiplatelet therapy, strategies to bring down cholesterol, the cardioprotective medications, and the risk factor modifications. So let's start with the antiplatelet therapy. This therapy is going to be, generally speaking, a dual therapy with antiplatelets. That means aspirin of 81 milligrams once a day plus one P2Y12 inhibitor. A P2Y12 inhibitor is a family of the medications that inhibit that protein that you see in blue in an S shape. It inhibits that protein in the membrane of the platelets and stops or prevents activations and additional platelet accumulation. This combined therapy with 2 antiplatelet, as a general rule, we're going to leave it going for 12 months. And the P2Y12, the most common ones we use, or BP, in a maintenance dosage, which is when we see them in our office, is clopidogrel or Plavix, 1 tablet a day of 75 milligrams. Plasogrel or Efficient, of all of them, I would say is the one we use the least because it does have some counterindications. The doses is 10 milligrams once daily, and if he weighs less than 75 kilos, it's about 5 milligrams. And triglyceride, which is 90 milligrams twice daily. Let's continue. An important observation is that the patients that are allergic to aspirin will only stay on P2Y12. They would be in a monotherapy with a P2Y12 inhibitor, which are here, and with the maintenance dosage accordingly. And with the clopidogrel, it's important to look at it because it metabolizes through the CYP, the 2C19. We must avoid it. We must avoid giving it together with omeprazole or omeprazole. We can use prazole, which is not metabolized so much with that protein. It's a little bit less potent than Brilinta or the ticagrelor, but for many years it has been our first line of antiplatelets. But today there have been studies and there are guides that have changed, and we should start first with Licagredol with the patients once they leave the hospital. Okay, as I said, Lasurel is not used very often because it's counterindicated with patients who had a stroke before. It's adjusted to the weight of the patient, and we usually do not use it with patients older than 75. And Tricagrelor is our first line of attack. In our secondary, it can make some patients a bit dizzy. They get tired a bit more easily. Some have reported it, a recurrent cough, but unless it's something that's really affecting their quality of life, we try to leave them in this therapy, which is the strongest one. And then after 12 months, we have a maintenance dosage, which instead of being 90 twice a day, it's 60 milligrams twice a day. I will mention it further on. Okay, we have two groups of patients that leave the hospital after a heart attack using that dual therapy. These first patients are those who do not have indications of taking a DUAC, of not having an anticoagulant. So let's say as a general rule that these patients that need a thinner or an anticoagulant are the ones who have fibrillations, which we spoke about before. This group does not have atrial fibrillation, so it leaves the hospital, and it doesn't matter if the patient has or not a NET. If that patient is diagnosed with an acute coronary event, that patient will keep the dual therapy for 12 months. Why? Because what we presume is that coronary suffered physiologically a, a rupture of that platelet in arteriosclerosis, and there was a clot that blocked or partially blocked it, so the artery is inflamed, it's hurt, and it can close up again, regardless of the presence of an extent or not. So let's go over it again. So I'm going through the left to the right on the table. If the patient, the first graph, the first column, which is green, it says the patient passed the 12 months from the event, PCI or not, meaning with or without an it, then we're going to leave them in a therapy of aspirin alone. Second event, if the patient has, I mean, second column, if the patient had a coronary event, went through the 12 months in his dual therapy with aspirin and the PY2 inhibitors, and then after the 12 months, this patient has a high risk of having a re-event or dyschemia, then we can consider leaving that dual therapy for 3 years, which is the third point in the bullet. A high ischemic risk, we could consider it. Now, who is usually in this category? Patients who first have a secondary event early on in life. We've seen them in the office, 40, 50 years old. These are patients where we want to be extremely aggressive with the therapy. Patients that when the cardiologist calls us and writes in the report, look, there was a complication with the catheter, there was a dissection, the net I had to put was too long, I had to put more than one artery, I had to put millimeters, a, a thicker net, and things like that. So we adding that to the history. So we see the probabilities of another event is higher, so we become more aggressive. The third column that we see, we're already entering, as I say, in two groups of patients of a high risk of bleeding. Strategy number one, to treat these patients that had an event, an infarct event, is to leave the dual platelet therapy just for 6 months and then leave them on aspirin alone. That would be the third column down. And the fourth column, which is the second strategy of patients that are at a high risk of bleeding, is to leave them with a double therapy from 1 to 3 months only, and of those 3 months up to the year, continue with just one P2Y2. Okay? and then decide whether we leave them on aspirin or we continue with P2Y12. Nowadays, we don't use the premetal stents. We use drug-eluting stent, which are the ones that have medications that avoid them from getting clogged, and they're much better from the ones in previous years. And these guides have come out with the evidence that there's a risk of the net getting clogged, but still we want to be aggressive, especially throughout the first month, and we want to say with an antiplatelet therapy. But as a general rule, 12 months, and that patient will be in dual therapy of antiplatelets.
Now, in the groups of patients that we had, that they have a history of atrial fibrillation, we see that in these patients, we're going to see they're going to stay in an antiplatelet therapy, let's say Plavix, and Plavix is the one that we most likely will select, Apudravel. That'll be the P2Y12 that we would select for those that have atrial fibrillation. We're going to combine them with an anticoagulant like Elitix. So it is not rare to see in the prescription Plavix plus Eliquis. It is very probable that that patient came from an acute event and they have a history of atrial fibrillation. Now that therapy will remain like this for 12 months, it's a general rule, and then it will continue indefinitely depending on their stroke risk with the DOA, which would be the anticoagulant, the DOAC. Now, patients that have a high risk of bleeding, which is the middle column on your screen, we're going to continue with anticoagulant with antiplatelet for 6 months, and then the anticoagulant indefinitely. And the third column, the patients that have high ischemic risk, the most we can extend a triple therapy is 1 month. This is important to know. We have not seen any benefit of adding and extending a triple therapy more than 1 month. And a triple therapy is aspirin, Plavix, and an anticoagulant. That we should not see under any situation more than a month. 1 month after the event, of course. Next slide. For reference, these are this is the dosage and the different anticoagulants. Now, the second strategy is for us to reduce cholesterol. And our first and our best in our arsenal is statins. That's our gold standard medication. It's going to inhibit the production of the protein, which is an HMG-CoA reductase, which is in the liver. Now, that protein, what it does is that it creates more cholesterol, and when it's not created, there's an upregulation where we start to see more LDL receptors. And this way, we capture more triglycerides. But it's not only important for the statins to reduce the number of total cholesterol, that yes, we have some specific goals and we're going to see them further on, but also the most important prevention comes from the change that we see in the plaque and how that statin can help in a reduction of these inflammatory markers. And it is a common question that we ask, and is, well, does this reduce the plaque size? Well, it depends. The size is not the most important thing, although it can reduce between a 6 to 8% from what we've seen from research in terms of size of volume. But that is not the most important part. The most important thing is to stabilize that plaque. That plaque has inflammatory markers. What we want is to that it's not as inflamed, and we're trying to prevent from more to start to come loose. So we see this as a reduction in the lumen of that plaque. Now, for statin medication, we normally start with atorvastatin or rosuvastatin. Why? First, these are the statins that have the more scientific studies under their belts, and it's those that we can take to the higher dose. And in that higher dose, we can see up to a 50% reduction in the calculated LDL. So, as a general rule, if I have a patient and needs to start him on statin, I'm going to go to one of these two medications. Now, if I work with one and it's not being tolerated, they start with muscle pains, I move from one to the other. They say I start with atorvastatin and then I go to rosuvastatin. If they can't tolerate that one either, I would go to another statin. But as a general rule, I'm going to see that I start with atorvastatin and then rosuvastatin. And I remember this because a chief told me, "Hey, don't forget arroz. Don't forget arroz. ARROS. Those are the best two." So they reduce cardiovascular events. If we have our patients in statins, we're going to reduce those cardiovascular events. Next slide. This changed in the new guides that came out in 2026. The LDL goals are stricter now because we have seen that if we're able to reach these numbers, we can reduce the incidence of cardiovascular events. So if the patient is a very high risk patient, what you see here are two major events, ACS, stroke, or arterial disease. You have two of those or a combination of one major event plus two high risk conditions, which are the ones that are described in the blue box. That patient has an LDL goal of equal to or less than 55. Now, if they only have one of the high risk conditions, they're still considered high risk, and then it is 70 or less for the LDL. So we have at very high risk and high risk. So what if the patient has intolerance to statin? We should give them about a 1 month washout in between medications. We could recommend for them to use them 2 or 3 times a week instead of daily, or we could switch completely to ezetimibe of 10 milligrams or PCSK9 if it's a high-risk patient. So this strategy is more on patients that are not high risk, because if we have a high-risk patient that has intolerance to statin, we're going to recommend a PCSK9 straight up. Zetia, the way that it works, it inhibits the absorption in the intestine, of cholesterol in the intestine. That's how it reduces the LDL. As a monotherapy is not as effective, only 18% reduction. And with the statin, we get up to 25%. We have seen in studies like the IMPROVE study that adding ezetimibe to statin therapy after an ACS event reduces the incidence of cardiovascular events. These are the PCSK9 inhibitors, and the most known one is evolocumab, which is Repatha, and it prevents the degradation of the LDL of the PCSK9 on the LDL receptors. So we have more receptor production. These are very effective, expected reduction up to 45 to 60%. They're administered subcutaneously, and they're used for patients that got to the maximum dose of statin and were not at the goal, or in patients that are high risk that do not tolerate statins. Next slide. Here we see the cholesterol control strategies for high-risk patients. We start with statins. We should be able to get to a 55 or 70 on the LDL. Now, if they don't tolerate them, we go to the next set of medications. Triglycerides. Now, in patients that had some kind of cardiovascular events, or those that are diabetic, it is better for them to start on sacubitril, which is Vascepa, with the reduction of cardiovascular events, and we're using the Reduce It trial. We see patients that have between 150 to 199. Now we see triglyceremia. We start statins first. Then we try to go to the maximum dose on that statin medication, and we see perhaps what other causes might be impacting the triglycerides. The second or third step would be to add Vascepa, which should be 2 tablets twice a day. And in these patients, I always recommend it's like a fish oil, and it's very strong, has very strong fishy smell and taste, so keep it in the fridge. Same thing, but explained in a summary on this chart. Next slide. Now, patients that have severe hypertriglyceridemia, that's where we start with other medication, including the fenobric acid and fenofibrates, and gemfibrozil, because it has an possible interaction with statins, gemfibrozil, lipid. So lipid is used if the patient have any risk factor, is very young, and has a severe hypertriglyceridemia, but we don't favor it as much as we do the first two, the fenofibrate or the fenofibric acid. Cardioprotective medications, the ACE or the ARB, the ACE inhibitors, so the ones that end in pril, and the ARBs are the ones that end in artan, losartan, mesartan, etc. These are the indications for patients that have had one ACS and hypertension, diabetes, or a STEMI that has been happened from before. Second protective medication are the MRAs, aldactona, and eplerenone. For the most part, the patient has an event and an LVEF less than 40%. We will see the medication. Next slide. Historically, the beta blockers had been part of that arsenal in the toolbox for secondary prevention, but that changed. The beta blockers, the benefit for patients to eternally be on a beta blocker is because at some point they had a stroke. The benefit of that is uncertain. That's why the indication is not a class 1 indication. It is a class 2B indication. So depending on every case, we can decide if we will start them or not on them on a beta blocker. The only time that we will see the patient does benefit from having a beta blocker therapy is in two specific scenarios. One of them is in patients with where we have reduction, where we see a preserved EF less than 50%, and two, when we have ventricular arrhythmias, either heart failure less than 50% on the LVEF or ventricular arrhythmias. Otherwise, we will do it on a selective basis to see what patients might benefit from having a beta blocker added to their medications. Where do we see or where do we use the beta blockers in those patients that continue to have angina? And we use it as an anti-angina medication after a cardiovascular event. Next slide. Now, this is one of the most important slides because we see these not only in secondary prevention as in primary prevention. Who would we start on an SGLT2 or DARLING? It would be diabetic patients on dapagliflozin or enaplazine, patients with diabetes or CAD, they do benefit patients that have a lot of risk factors and diabetes, and lastly, if they have a chronic kidney disease, whether stages 1 through 4, or if they have a albuminuria more than 300 milligrams per day. Next slide. Now, let's talk now about the anti-anginal medication. The first look are the calcium channel blockers. And we're talking about verapamil or diltiazem. This could be the first line of defense or the first line of action. Diltiazem is generally better tolerated, but it's very important not to use them when the patient has a reduction on the ejection fraction or in the blood pressure. What we prefer is to use the beta blockers, which have their indication for those specific things when they have heart failure. Now, beta blockers are a second anti-anginal medications, second group. And the ones that we prescribe the most are toprol or carvedilol. And carvedilol, since it is a beta and alpha antagonist blocker, it decreases the blood pressure more. We do not recommend to combine a beta blocker with a calcium channel blocker because it should exacerbate bradycardia events. And our third, well, no, we still have the nitrate. Our third anti-anginal medication is ranolazine. Next slide.
We can continue this way. Usually the way we do it is we start with a beta blocker, and after that we move to a nitrate, and we go adding one after the other. And it depends on the limitations that we have with some of the medications. For example, I have a patient that I can, as an anti-anginal, I start with a beta blocker and I see that the pulse is going up to 60. I cannot continue with the dosage. So the next medication I add is a nitrate, and I try not to coordinate. If the nitrates gives him too much of a headache, well, then I should consider maybe a beta blocker or the channel blocker, and so on and so forth. We can combine the therapy of mononitrate, and we can combine it with 1 tablet a day and add nitroglycerin sublingually insofar it is necessary during that time of the day. The nitrates are counterindicated in these scenarios in cortical aortic stenosis and hypertrophic obstructive cardiomyopathy. We can continue. As we know, the blood pressure, we're going to try to get under 130/80. Let's continue. This is very important. There's a study that came out this year, in May of this year, and what it tells us is that collectively we have done a very bad job getting our patients to the goals in secondary prevention with events of cardiovascular events. The blue graph tells us that only 50% of the patients that have had an event have arrived at the goal of blood pressure under 180 and 130/80. Then we have one that gives us a good diabetes control, the one in res. We have the LDL in 70 and the one in under 55. We have barely gotten patients there we've seen that, that they get their baby in a 17-30%. So definitely, collectively, it's very important that we get to these goals and that we work a bit harder. Next. What are we going to tell them about physical activity? What we know, more than 150 minutes of moderate intensity aerobic physical activity and 75 if it's vigorous. Adding at least twice a week with exercise with weights or resistance type of training. And at least something that makes you move more so that you don't become so sedentary. Let's continue. As far as nutrition goes, also, we know what the guides say, and they establish that we need a Mediterranean diet I always tell them the same. We don't have to find anything out there, nothing in TikTok. It's just about a diet where you feel good, that you enjoy, that you don't demonize your diet, and that it includes lots and lots of salads, fruit. The best protein is fish, sardines, salmon. The second one is the the ones that do not have a lot of fat, like chicken and turkey, and to try to avoid red meat to maybe once or twice a week. Let's continue. This study basically was the study that gave indications. It gave Mediterranean diet, class one diet, so we could see the ones who had it and didn't have it, that there was a big divergence. Following the Mediterranean diet, they saw how events reduced and the incidence reduced. So you don't only have to be doing this for a year. Just to be consistent for a few months, you can see a decrease, a significant decrease in morbidity and mortality with this type of diet. Let's continue. Also, common sense, tell them not to smoke. And I think that I've noticed that the way to reach patients with this addiction is not just only to offer this alternative of medication that we have them, but also telling them that it's important that they consult with a psychologist, because I've noticed that many patients that have this smoking addiction, it goes together with a lifestyle. I don't know if I can explain myself. It goes with a habit that you relate it to their coffee or being together with friends, meeting up with friends. So it's important not just to look at the clinical side, meaning medication and so on, but also looking at the psychological aspect. So here are the alternatives we have to help them to reduce that craving. Let's go forward. It's always important to combine oral therapy, which is again ocripium or the Ozempics or any of those alternatives, although we prefer Chantix or Benclin, and combine it with a replacement of nicotine. That replacement includes the combination of a patch, a nicotine patch, plus, be it a gummy, the pouches that they take. Basically, it's the medication and the replacement of the patch. And every time it's necessary for the cravings, the gummy or yeah, or the gum, the nicotine gum. Avoid alcohol use. These are the limits for men. One for women. One to for men. Two. Avoid binge drinking. It augments the risk of, uh, and it's associated with a higher mortality rate. A very important topic is when they can reinitiate their activities and to have sexual activity. Sexual activity is considered uh, mid to moderate physical exertion, let's say 3 to 5 minutes, and it's the equivalent of walking or climbing 2 flights of stairs. It's very, it's not very probable that the sexual activity is the cause of another infarction event or cardiac event, but we recommend that you don't have sexual activity if you still feel with pain in the chest, tired, fatigued. Of course, we don't recommend it at that time, but generally speaking, after a week, if the patient feels good and it was myocardic event that was not very complicated and he has no symptoms, he can consider it. The same way, exercise. I was going to comment that another common question is, like, as a general rule, minimum wait for a week. And this is not so clear in the guides, but so it's a bit vague in that of what activities, what physical activities are good. But generally speaking, 2 to 3 weeks to begin something more established, more. If you want to walk in the mall, of course, because what we want is to avoid sedentarism. But if you want to start walking and walking a mile a day, I would again wait a week. If the patient, after the hospitalization, has a recurrent angina and requires insubordinate nitrate daily, then it's a bit more difficult to start them with phosphoric and sterase inhibitors like Viagra or Cialis for erectile dysfunction because they cannot be combined. Now, if the patient is only using nitroglycerin sublingually or when it's necessary, then we can recommend a medication of the phosphoricide inhibitor if they wait 24 to 48 hours after having nitroglycerin, because combining them can bring down the blood pressure and kill them. Let's continue. This is very important. We must always screen and monitor for depression because it's very common in patients after a cardiovascular event. Their life changes completely, especially the younger ones. It's very, very evident. So we need to keep our eye on that, to keep your eye open for mental health issues and conditions. Let's continue. I leave you a couple of points that are very important about a secondary prevention after a myocardial event, and these are my references. So thank you. Thank you, doctor. So now we're going to have the post test. The post test, you can scan it, what it says in the QR code there, or you can have also a pop-up screen with 8 questions. I'm going to give you a couple minutes to fill it out and to take advantage of the time. If anybody has a question for the doctor, you can use the chat or we can open the microphone. Any question, any doubt that you might on what the doctor presented, something that might have caught your attention? Any question about the treatments? I don't see any raised hand. I don't know if I hope I'm not mistaken, if I'm right. But over here, then we're going to present the clinical case. I remind you that the clinical case, any of you can submit a case. You will be getting an email with a link, but in the chat, we are going to include the form link so you can bring in the clinical case with the details of the patient. And there, Julio brought it up, put it up where it says to submit the case. So I go with Franceli for the presentation of the case. Go ahead, Franceli. Hello, good afternoon. We have for today a man, a 46-year-old man with hypertension and obesity class 1, lifestyle sedentary. He, he doesn't have any significant uh, family history, no significant premature cardiovascular disease, no surgical history. He does not consume tobacco nor alcohol. He had a myocardial event, infarction, uh, angiography, a coronary angiography, a complete total occlusion of the RCA, a PCA with the 2 stents were put in the right coronary artery. Medications that were given when he was discharged They gave them aspirin, 81 milligrams daily, orally, triglyceride, it can be Brilinta, 90 milligrams orally, BID, and atorvastatina, 40 milligrams daily, orally, and lisinopril, 5 milligrams daily. In the evaluation, the clinical evaluation, um, blood pressure of 132 over 92, heart rate of 62 beats per minute, RR14 breaths per minute, SpO2 of 99%, and he weighs 102 kilos and measures 1.73 meters, a BMI of 34.2 kilograms per square meter. As a key issue, he has a cholesterol, an LDL of approximately 85 milligrams per deciliter, and anginal system symptoms that are recurrent and persistent that require optimization of anti-anginal therapy. The discussion questions are there. What are the priorities for the secondary prevention? Is LDL C 85 milligrams DL adequate after a stem? How would you approach the persistent angina? And the fourth question, what, what lifestyle intervention and risk factors should be reinforced? We also have the labs. This is the EKG. I don't know if you want to fully delve into this. As you wish. I can go through the case, but we also have the electrocardiogram, the echo, and labs. I don't know if you want to, there are other recommendations. Losing weight.
So I can wait, or we can listen to what the recommendations. We see here some dash diet, uh, weight reduction, and the doctor will be providing a summary at the end. Kathy mentioned the goal blood pressure should be 130 over 80. Also, better uh, blood pressure control and physical activity. So, in summary, and this is a real case, 46-year-old male, hypertension, class 1, obesity, BMI of 34. No, not a smoker, not drinking, but a sedentary lifestyle. He didn't exercise, nothing in his family history, and he had a STEMI, an inferior STEMI on the right side, and then we required 2 stents on that RCA. The only thing that I brought is not the picture of the uh, catheter, but it is very impressive to see when you see that complete total occlusion versus when you have the stent. So you have the before and after, left and right. Now he's on a on dual antiplatelet, Brilinta 90 milligrams, atorvastatin 40 milligrams, and lisinopril of 5 milligrams, which who which he was already using for his hypertension. When I see him in my office, we do the physical exam. He looked okay. we didn't see anything of concern. The pressures were way above the goal. The goal is 130/80, and he was on 138/92. Heart rate pretty normal. Everything else was fine. His BMI on was at 34. Now, initially, the lab work, the ones that we see here on screen, and that LDL was an 85. Let me see if there's anything else that is relevant here. Hemoglobin at 15, plaquettes on 185. The glucose was fine. He wasn't pre-diabetic. Didn't put it here, but his A1 has always been good. Creatinine was fine. Electrolytes within normal ranges. And then in the cholesterol panel, LDL calculated at 85, triglycerides in 165, at 165, the triglycerides. Next slide. The LDL calculated was at 85 and triglycerides at 165. Now his echo, normal EKG, no evidence of KUSE or a previous failure. Now we have the stress test. So with the electrocardiogram, many times after a stroke, we do see halters, which are the same electrocardiograms, but for a longer amount of time. But we didn't see any arrhythmias. And then on the echo, the ejection fraction was at 55/60. That's study, or was within range, normal range. This mitral valve, we do see a minor leakage. Appears to be secondary to tethering of the posterior mitral valve leaflet, which is one of the areas that we had some issues that didn't receive enough blood. So if you see this circle down there, what that reflects in red is that wall, which is the inferior part of the heart, which is represented by the right uh, artery, is akinetic. It's not moving correctly. Besides that, everything else looks relatively normal. That's a wall motion summary. I'll leave the stress test for later. If you go on the 4 points as I divide them, that we spoke about, dual antiplatelet therapy, strategies to reduce the cholesterol, reduction of the lifestyle, and cardioprotective medications. First of all, he is already on his dual antiplatelet therapy. Let's just check on one. Now, this patient, we're going to keep him 12 months on that dual antiplatelet therapy. Again, in most cases, we're going to choose Brilinta because it is stronger and more effective. And two, this patient is a good candidate to extend this dual therapy up to 3 years. And I talk to them from day one. I tell them the goal of the 1 year goal, and I give him the date. His incident was June of 2025. We're going to be on this all the way through June 2026. I would like to extend this because you're a young patient. I'm more aggressive with you. I want to reduce chance of a restroke. You had two stents that were placed in you. So we're probably going to extend that up to 3 years, but minimum 1 year with two medications. At the second point, the lipid-lowering agent, he's already on a maximum dose on statins, even though we could bring him up to 80, which, as a matter of fact, is what I did, to increase that statin, azathioprine to 80 milligrams, and he was tolerating it rather well. And for the reduced trial, I also put him on Zetia. So we went to 80 on, we increased Zetia. I'm sorry, we started Zetia 10 milligrams. And three, eventually we started with Vascepa. And I waited. We started that combined therapy of the lipid lowering agents I think I saw him a month later. I saw that the LDL had decreased to the goal. This patient's goal is 70 based on the guides. Theoretically, he only has one high risk event. He has an MI, and in the high risk conditions, hypertension. So theoretically, he doesn't completely qualify for a very high risk as a very high risk patient. Nonetheless, I'll be completely honest with you. And in my practice, we brought him down to less than 55, the calculated LDL. And I think that another thing that I added in this scenario, and I put here, but he did have an LP little a that was high. So that was source of concern. And I wanted to be more aggressive with his uh, medications. But minimum, we need to bring this down to 70, the LDL, which we were able to achieve that. After this, I saw that his triglycerides were still above 150. And I added Vascepa, which is icosapent ethyl, 1 milligram tablet. It is two of them twice a day. So 4 milligrams, not milligrams, grams, 4 daily grams, which is what we saw in the reduced trial that it did reduce cardiovascular events, even if there was no reduction on triglyceride numbers. But you will see them. So we spoke about the lipid-lowering agents. We spoke about the antiplatelet management. The third one, lifestyle modification and risk factors. And I see it in all of your comments. Yes, uh, blood pressure goal. I think we increased the lisinopril dose to get to our blood pressure on the 130/80. And we explained the patient about a med diet to prevent sedentarism, start to do exercise. And sometimes we have to be very specific and creative because if you say 150 minutes a week of moderate intensity, sounds, sounds like a lot, or they don't know what to do with it. And I give them examples. That means that you can walk 15 to 20 minutes daily, and then you add them 6, 7 days a week. Or if you do 30 minutes, it's 5 days. If you're walking and you're talking, you're there at a moderate intensity. So I even give him numbers on a treadmill. That's like a 3 on a treadmill. And the key is that if you give them more facts or if you give them more specifics, it is easier for the patient to follow. Same thing with the plate. I do tell them, Mediterranean diet, but I give them example of what to eat. You can eat your rice, but maybe 6 ounce cup. Uh, Nutritionist, please don't kill me. This is how I try to make this come alive for them. And, don't put the avocado, add more salads, add some root vegetables. Salmon is better, etc. What I'm trying to say is we need to be more specific, more concrete with our recommendation. Third point, cardioprotective medications. If the patient already has hypertension, we're going to use those cardioprotective medications to treat the hypertension. Like I said, like the ACE inhibitors or the ARBs, and the ACE inhibitors include leronidazole. Now, this patient was challenging, but he did have chest pains, and his chest pains felt like pericarditis. We don't know if it was more like an angina, chest angina. It was a big challenge to distinguish between one diagnosis or another to see what was the correct treatment for him. But assuming that it was an anti-angina and that it was angina for that, it really limits their capacity. It's like having this constant fear every time that they have like a chest pain, anything, they go back to that time, to that instance. And that's where we just also keep track of their mental health because they do get depressed. But I do explain to them ahead of time, it is possible that you will feel some chest discomfort, that angina, and that angina. The classic angina is going to come when you're trying to do a lot of physical activity. There's an artery that we just open, or that is open little by little, takes blood to the muscle. And when you're doing exercise, when you're stressed, the muscle starts to beat faster. So it requires more blood. And that artery is still little by little getting adjusted to vasodilate and to open correctly. So that mismatch between the muscle blood requirements and the blood supply, you will get that angina. Now, not all angina events are strokes to they're not myocarditis. It doesn't mean that that muscle is dying. No. And it's important to describe this to them because it gives them a little bit more peace of mind. For anti uh, angina events, to control this situation, we put him on toprofloxacin, and I started with the lowest dose, 25 milligrams. And that's something that we did just as we continue to like uh, better adjust for those chest pains. What else? If the chest pains would have continued, my strategy wouldn't have been to add Etrapol because his pulse was already borderline, like it was at 62. And I would have perhaps added maybe an Endure if the chest pains are daily. If the chest pains are not as recurrent, if the anginas are not as recurrent, and maybe it's once every 2 weeks or once a week, the patients explained that better to use a sublingual nitroglycerin. And lastly, and we spoke about antiplatelets, lipid-lowering agents, cardioprotective medications, and changes, lifestyle changes. Now let me see what else I saw here on the chat. GLP-1. Yes, and that's a very good point topic because yes, we're definitely seeing a lot of data and new data. And I'm seeing Dr. Roman's comment. Yes, these patients, especially patients that are on class 1 obesity, if we start them on GLP-1 medications, there is strong data that says that we can reduce cardiovascular events, both the morbidity and morbidity. But it's hard. In practice, in our practice, it's a bit frustrating because we see the indications to be able to use these medications, but even though I justify them, it's very difficult to get them approved by the health insurance plan, even for them to pay for them, even with coupons, it's still $125, $150 a month, so it's hard. And yes, lastly, and this is where the stress test, and it's really going to depend on the cardiologist, but I like to do this stress test because ideally they would go to a cardiovascular rehabilitation center, which we don't have them in Puerto Rico. So my way of trying to get a bit close to that gold standard in management is to do a stress test to see first if there's ischemia evidence, or to give them more context of the prognosis, letting him know, for example, if I see any kind of arrhythmia, if I see a lot of ventricular prematures, if I see that the blood pressures go up too high, or if we see blood pressure drop during exercise. But throughout this study, we every 3 minutes we increase the speed and the inclination of the machine, the slope, and that's where when you see the stages, each one of those in the protocol, you have a speed, a specific speed. And this is done with, so if I do a bruise here in San Juan and Guaynabo, and somebody does a bruise in Ponce, it's the same study and we all understand what that means. But basically, in each one of those days, the goal is to get to 85% of the maximal heart rate for that patient. And during each stage, we see the blood pressure. And why do we want to get to the 85% of the normal heart or the normal heart rate? Because it's just at that point is that where we want to do our ischemia evaluation, which means to see if the heart muscle is receiving the amount of correct blood to be able to feel well. Because if the heart muscle is not getting enough blood, there are some changes that are reflected in those lines, especially in the ST segment.
So with this information, I can recommend medication for the patients. For example, if I see more arrhythmias or CVCs, to use the beta blockers, or if I see that they have too much ischemia and we get to 85% of that maximum heart rate, and I notice that there's depression in this ST segment, I know that I must tell them, let's go little by little. Let's extend a little bit more in terms of starting a more strenuous routine. So this first week, let's just walk. So direct that therapy a little bit more. Within an ideal context, this should happen in a center that's one-to-one with the patient, that has his cardiologist, the physiotherapist, and so on. So I give him strategies based and personalized depending on the cardiovascular risk and the prognosis. And if everything comes out well, as their studies, there was no ischemia. Study, there was 85% of his maximum heart rate. I didn't see premature, I didn't see any tachycardia. So the rhythm after the event, 4 weeks after the event, I saw that it was low risk. We look at that little number. If you see it there, it's a BTS. It's a D plus 8. So we give them recommendations of low risk, and we can tell them you can exercise in 1 or 2 weeks, and we go little by little, etc. There is a limit of age to recommend that study? No. We can recommend it at any age. This will be, I mean, we don't have so much data on this. These are very small studies. I think that the randomized controlled transcripts have very few people, very few participants, but we don't have a minimum data. I mean, minimum age or maximum age to say, no, you can't do a treadmill score, we can't do a stress test. Where I would not recommend it is in patients have that still have a lot of angina. We shouldn't do that with them. Two patients that have some kind of residual coronary disease, if one was revascularized but another one was left to be done at a later stage, I wouldn't recommend it. Or to patients that have any residual cardiac disease, at least not at the moment. I don't know if we have any others. Let's wait a little bit for any other questions. Thank you, Dr. Rodriguez, for such a wonderful presentation of the case. I have here, let me see if in the chat there's anything. Nope. Okay, super. So I will then continue with the presentation. We'll have some announcements to make. I will put the satisfaction survey up so that you can go filling it out so that it's going to be on screen. There it is. It's open. And there you have it in the pop-up. You can also do it through the link in the chat, and you can access it there. And we have next session the 25th of August, with obesity as a cardiometabolic illness. And we will have Leticia Hernandez, and we expect to see you here in the next section. And we also have the conversation on digital health in Puerto Rico panel. But now we have a space for the 20th of August and the 25th of August in Ponce and Atillo. So registration is here on screen. We also have the digital library where this session will be recorded, and the library recursos.prpht.org, where we will find the presentations and the cases. So I will look at the chat once more. I don't think we have any other questions. So thank you to the cardiologist, Maria Rodriguez, for having been with us today. And we hope that we can count on her later on. Thank you. At your service. Thank you and good afternoon. Good afternoon. We'll see you next week. Thank you.